Today, I'll be talking about modeling needs for screening and resource specialty care in the U.S. Veterans Healthcare System. My name is Aparna Reddy, and I'm an undergraduate student at the University of Michigan School of Public Health. And this research is in collaboration with Dr. Nithya Ramnath, an oncologist at the Veterans Affairs, as well as Dr. Amy Cohn and the team at CHEPS. CHEPS is a Center for Healthcare Engineering and Patient Safety, and is located at the University of Michigan in Ann Arbor, Michigan. At CHEPS, our goal is to help improve healthcare-related problems through an interdisciplinary approach with engineering. For example, earlier I mentioned that I'm a public health undergraduate student and might be the only one at this conference. But my role at CHEPS is to bring my understanding of population-based health, understanding of interventions, and social determinants of health. We also have industrial operations engineering students on our team who bring their perspective of a systems way of thinking, as well as computer science students who help us bring our solutions to life with code and algorithms. In addition to our interdisciplinary team at CHEPS, we also work with clinicians led by Dr. Nithya Ramnath, an oncologist at the VA, as well as representatives from the Veterans Affairs. And it's through this collaboration that we can bring all the different perspectives that we need to do our research. So when you think about clinical interventions, there's three types. The first is a primary intervention, which involves intervening before a health effect occurs. This can be through immunizations and different educational programs. A secondary intervention involves identifying a disease at an early stage. This can be through regular exams such as blood pressure measurement and screening tests. A tertiary intervention involves managing a disease after its onset to slow its progression. This can be through rehabilitation programs and different forms of medication. While our research can focus on all these types of interventions, today's talk is specifically going to focus on a secondary intervention, specifically on screening tests. But why are screening interventions so important? It may seem that if we focus all of our energy on primary interventions, we can help prevent diseases from occurring in the first place. But that's not always the reality. Even with primary interventions in place, there are often patients that are still at greater risk for certain diseases. And with a secondary intervention, we can add an additional layer to help mitigate these outcomes. For example, with screening, we can allow for an early detection of the disease, which allows for more time to implement treatment, more treatment options, and ultimately a less invasive treatment. For example, if a patient is diagnosed with cancer at an early stage, we have the chance to help provide them with a less invasive surgery just to remove one tumor, rather than a fully invasive chemotherapy session that can impact the entire body. There are lots of examples of how screening can improve outcomes. One example is for melanoma, a type of skin cancer, which when detected at an early stage has a 5-year survival rate of 99%. However, when detected at a later stage, this drops all the way down to just 30%. Similarly, for colorectal cancer, when found and detected at an early stage through a colonoscopy, the 5-year survival rate is 90%, as opposed to the mere 14% when detected late. In addition, for mammograms, which are a form of a screen that can help detect for breast cancer, they are now a standard practice in care and have contributed to about a 40% decline in overall breast cancer mortality. These are all just a few examples of how screening can improve overall outcomes. Another example is for non-small cell lung cancer, which is what our research focuses on. Lung cancer is the leading cause of all cancer-related deaths, accounting for up to 20%. However, when lung cancer is detected at a late stage, the 5-year survival rate is only 8%. But this can improve all the way up to 56% when detected early. However, the problem is, only 16% of lung cancer is diagnosed at an early stage, which is why it's important to help screening to help detect lung cancer early. But how can lung cancer be detected at an early stage? This can be done through a low-dose computerized tomography scan, or an LDCT. An LDCT is very similar to a CT scan, except it uses a lot less radiation and can occur much faster for more frequent screening. LDCTs have a sensitivity rate of about 93.7%. And of the cancers detected by an LDCT, about 77.7% are detected at an early stage, which shows that LDCTs are key to detect lung cancer early. But the intervention isn't just about the scan, it's about who we can give the scan to. Which is why the next question is why the VA is so interested. Well, there are about 900,000 veterans that are at risk for lung cancer every year in the United States. And this is due to a variety of factors, including age. as some veterans tend to be of an older age group, which not only puts them at risk for lung cancer, but other forms of cancer as well. Some veterans also have a history of smoking, which is an added risk factor for lung cancer. In addition, their very act of military service has exposed some of these veterans to things like radon gas and Agent Orange, which are added risk factors for lung cancer. All of these factors contribute to about 7,000 veterans that are diagnosed with lung cancer every year in the United States. And of those veterans, the most common diagnosis is a stage 4, or a late stage of lung cancer, which is why the VA's goal is to help improve these outcomes through early detection and treatment. And the VA hopes to do so with the Lung Precision Oncology Program, or LPOP, which is part of a national initiative called the National Precision Oncology Program. This program consists of an integrated network of about 23 hub sites, as you can see in this map here, with the goal of improving screening for a variety of forms of lung cancer. Specifically for LPOP, the goal is to increase lung cancer screening and provide precision oncology care. And our work is specifically with hub site number 10, located in Ann Arbor, Michigan. Like I said, our work is in collaboration with the VA Ann Arbor Health System to increase the screening rate of eligible veterans in Michigan through the LPOP program, which is led by Dr. Nithya Ramnath. Dr. Ramnath has received a grant to develop this personalized program, which includes smoking cessation, access to clinical trials, as well as screening. Specifically for screening, the goal is to increase the screening rates of eligible veterans from 5 to 30%. But why are we all here? Well, in order to successfully implement an intervention, we need to bring a variety of different perspectives to the table. This includes laboratory scientists who bring their perspective of diagnostic tests and treatment, clinicians who have an understanding of the oncology and physiology of the disease, as well as representatives from the Veterans Affairs, who bring their perspective of the cultural relevance of screening. But there's still one piece that's missing, and that's the expertise in this room of operations research. Although all of these different perspectives bring their understanding of the program, for example, that we might need a nurse navigator to help implement the program, there's not necessarily an understanding of how many nurse navigators. Is it 1 FTE or 3.5 FTEs? Oftentimes, there's actually an incentive to underestimate these resources in hopes to receive adequate funding. And that's why our role at CHEPS is to help develop this operational support to implement this program. But why is resource allocation so important in the first place? Earlier, I talked about all the different forms of interventions and how they can be very successful in improving overall outcomes. But despite all this evidence backing up the success of an intervention, sometimes interventions still fail due to an underlying cause of inadequate resources. And when this happens, there's an increased skepticism for the idea of the intervention, which then reduces overall clinical buy-in and makes it more likely for future interventions to fail. In order to break this cycle, it's important that we address the underlying root cause of inadequate resources. But how can we do so? Well, when you think about an intervention, there's initially a general source population that the overall intervention aims to target. And then there's a series of actions that must occur that consume certain amounts of resources until this population is narrowed and ultimately the goal of the intervention has been achieved. This may seem a little bit abstract, so let me give you an example of the LPOP program. This is a very simplified tree of the program where each node in this tree represents a specific decision point. For example, let's say that the overall VA population is 100,000 patients, let's say in hub site number 10. The first decision that must occur is whether or not these patients are eligible. This includes a variety of factors, including age and pack years, which essentially is calculated by multiplying the number of cigarette packs smoked per day times the number of years. And these points are essential to help determine the patients that are that would most benefit from the screening. And in order to determine this, it takes about 10 minutes for each nurse navigator to determine this and calculate eligibility. From this first decision point, let's say about 70,000 patients are not eligible and 30,000 patients are. The next decision point is whether or not these patients receive the screen. And this will involve about 5 minutes of each primary care provider to discuss the pros and cons of the scan. For example, some patients may decide not to be screened because of a personal preference, or they may not be screened because they have other chronic conditions that precede a lung cancer test. However, let's say about 20,000 patients are not screened and 10,000 are. The next decision point is whether or not these patients are diagnosed with cancer. In order to determine this, it takes about 20 minutes for each radiologist to conduct and interpret the scan. And let's say about 9,800 patients receive a negative result and 200 patients test positive for cancer. And then this will lead the oncologist to follow up and provide resulting care. With this model, we've developed 4 approaches to determine overall resource needs. The first is a static and deterministic model, which is very similar to what I described earlier, where we can calculate the total resource use by given a population and associated probabilities. We can determine this by multiplying the number of patients times the resource needs per each patient across each node and then summing it. But not all resources are used at the same time. They occur over a period of time, which is why we've developed the dynamic and deterministic model, which accounts for the steady state of this model through a longitudinal component. And this can also allow us to consider follow-up times. For example, this process map includes all of the different follow-up times at each node. For example, some patients who are not eligible or do not be screened will have a follow-up in the next year. But then some patients that receive a negative result may be followed up in 3 to 6 months, or might need to be rescanned in about a month if there's an uncertain test result. Or maybe the patients that are tested positive for cancer need to be rescanned again to determine a more clearer scan to determine next steps. All of these follow-ups can be accounted for through the dynamic and deterministic model. But in addition to all of this, there's still variability. For example, some patients may require more time through a discussion with their PCP if they prefer not to be screened even though the PCP thinks that they should receive the screen. And this will involve a longer conversation that takes more time with the PCP. Similarly, there might also be more patients in the month of January as opposed to the month of July due to fluctuations across the year. All of this can be accounted for through a simulation model through the stochastic approach. And the fourth model is a stochastic scheduling or finite resources model, which essentially involves working backwards. If you have a fixed population of all the resources that you have in the program, you can determine the total patients that you're capable of serving. When we initially worked on this project, we spent a lot of time trying to understand the program's needs, goals, and challenges. And we helped develop the overall process map to include all the different nodes as I described earlier, but in greater detail. Ultimately, with this map, we implemented the static and deterministic model, which included all the inputs, and in order to determine this, we did a lot of time studies and observations to help understand the resource needs for each task. Ultimately, we found that the needs of the nurse navigators was severely underestimated, as was seen in practice. And by informing the VA of this finding, they ultimately hired an additional nurse navigator to help address this bottleneck. Currently, we're working on the dynamic and deterministic model to account for all the follow-up times of the program. And as we wrap up our work on determining the overall steady state of resource use, we're also hoping to lay the foundation to implement the stochastic model to account for additional variability of the program. In conclusion, interventions are key to improving overall health outcomes. But in order to do so, it's important that we address the resource needs as well, which is why we developed this structured approach to determine overall resource needs, which not only calculates the overall needs of the program, but also helps support program implementers through the structured way of thinking when planning for the program. Ultimately, our goal is to improve overall health outcomes, not just for lung cancer in the LPOP program, but for a variety of other interventions as well. I would like to thank our collaborators Dr. Nithya Ramnath and Dr. Amy Cohn for their support on this project, as well as our team at CHEPS and Beth Kedros and Anthony Levesque at the VA. I'd also like to thank our grant and the Seth Bonder Foundation for all of their support. Thank you.